Thank you very, very much for this extremely kind introduction. Half of these introductions are lies, of course. No, I feel very, very honored to be here today and to deliver this name lecture. And because I know Joseph since many years, and I always had a lot of respect and for this extremely high-quality clinical research they've done and they are doing here in Hong Kong. And I've also had the opportunity to collaborate with them. We are running together a trial with James on pancreatic cancer, and it's really a nice, very nice feeling when we meet for scientific meetings on research. It's extremely rewarding for me and for my group. Thank you. The other point that I think it's extremely important in the experience here in Hong Kong is the multidisciplinary setting where this work is done. Medico-surgical department in GI disease are not so frequent around the world, and this is an example of something that works since many years and works in the right direction. I was trained in a similar setting in Brussels by Professor Kramer, and when I went back to Rome, one of my dreams was to try to replicate this kind of setting also in my unit. And I think that we partly did it because we are now working in a multidisciplinary endoscopy unit where surgeons and gastroenterologists work together day by day. And I think that a small part of the success we had in our clinical career is mainly due to this multidisciplinary setting. And this is my hospital, the Policlinico Gemelli, who is an academic hospital belonging to the Catholic University in Rome. And this small house here is the European Endoscopy Training Center that was founded now 11 years ago, and where we run all sorts of practical courses on animal models and other models. So what I would like to share with you today is some ideas. It's not a scientific lecture, this one. It's just a talk with friends. Some ideas on endoscopy, art, and science. First of all, I was looking for a definition of art. And I found this one by St. Francis of Assisi, so many years ago, almost 700 years ago. And he used to say that he who works with his hands is a laborer. The one who works with hands and head is a craftsman. But if you want to become an artist, you have to use your hands, your head, and also the heart. So you need passion. And is endoscopy an art? Probably yes, because there is a creative and constructive spirit to the practice. An artist is one who is talented and skilled in the practice and has some natural aptitude as well as an endoscopist. So both these descriptions can apply to endoscopy. So perhaps it is an art. Also, some colleagues in the past have had the same feeling. Haubrich in GI endoscopy almost 30 years ago wrote that almost without exception, advances in endoscopy have come about by virtue of a close collaboration between clinicians and artisans, and neither could have succeeded alone. But clinicians, to become artists, should therefore be driven also by the passion, if we follow the definition of St. Francis. But look at some examples in the past. These two guys are Japanese. One is a colleague, Dr. Shinya, in New York in 1968. The other one is Mr. Ishikawa, an engineer from Olympus, Tokyo, that has worked for several years in New York and the States. So Shinya had already an extremely large experience in colonoscopy. And in 1968, they decided that maybe once the polyp had been detected, could also be removed by endoscopy. Why not? So they designed a snare that you can see here. These are the original drawings of this idea. And they developed with Ishikawa all these kind of new devices, and then they sent everything to Hachioji, to Japan, to Tokyo, to get the answer. And the answer arrived after a few months, in '69. This whole idea is very dangerous, cancelled. No way. Look 40 years after, what happens? The effect of colonoscopic polypectomy on incidence of colorectal cancer, minus 76 in the US National Polyp Study, minus 66% in an Italian study. So everything has changed thanks to polypectomy. Another example. In 1970, the World Congress of Gastroenterology was held in Copenhagen. And this colleague here, again from Japan, Dr. Oi, if you look at the program, this is very small, you cannot read, but he was scheduled to speak about early diagnosis of gastric cancer. But then he arrived in Copenhagen and he spoke about something else. And he showed the first ERCP images. This was a revolution. The possibility of injecting dye into the bile ducts and into the pancreas. Fantastic. So many people started trying to do the same with some difficulties because of also of the endoscope that were available at that moment. This was the so-called Machida pan-fiberscope, and which had also lateral viewing, so it was possible to use it to cannulate. And in the 70s, these were the sentences written by people that were pioneers in ERCP. Peter Cotton, he still was in the UK, he wrote that the results showed that duodenoscopy and ERCP are technically feasible, potentially valuable, but not unduly hazardous. And a surgeon, a pancreatic surgeon, very well known in the States, White, also wrote that they were enthusiastic about the possible clinical usefulness of this instrument, but that it would only define the anatomic changes which had taken place in the gland, in the pancreas, so only diagnostic. 40 years after, if you look at the guidelines on ERCP of the American Society of Gastrointestinal Endoscopy, they say that ERCP is now a primarily therapeutic procedure for the management of pancreatic biliary disorders. So again, everything changed. The future is hard to predict. Look at these two examples. Thomas Edison, 1889, fooling around with alternating current is just a waste of time. Nobody will use it, ever. And Bill Gates in 81, 640K ought to be enough for anybody. Two good examples of how the future is hard to predict. Today, we have to face with EABM. But also EABM, to translate art into science, may have some problems. And there are inherent problems with EABM. Evidence-based medicine is not completely right. All evidence is not equally good. take care. Even if the quality of the evidence is classified properly, evidence can be contradictory. There are also inherent problems with randomized controlled trials, which are our God. Because diagnostic categories are sometimes not exact. And then the subjects in trials and other studies are seldom an exact match for the patients that a doctor is treating, so there might be some differences. Don't believe everything you read. If the paper is signed Costamagna, be aware. Try making your marriage better with a randomized controlled trial. It's a high risk of game over. So don't believe everything you read. Probably everybody of you knows this fantastic article that was published by the BMJ in 10 years ago, 2003. It's the only systematic review of randomized controlled trials on the use of parachute to prevent death or major trauma. And the results were that no randomized controlled trial parachute use have been undertaken, and then the basis for parachute use is purely observational, and its apparent efficacy could potentially be explained by the healthy cohort effect. But these authors also conclude that the individuals who insist that all interventions need to be validated by a randomized controlled trial need to come down to earth with a bump. They're probably right. I think that RCTs are the truth today. But, quis custodiet ipsus custodes, you have good results with your research, you want to publish it. The process of developing a set of evidence-based guidelines is not an entirely impartial and objective process when you go through all these guys that are your friends. So I think we should also try to have a new look at evidence-based medicine. Evidence-based medicine is not a cookbook medicine, is not a cost-cutting healthcare, and is not done only from randomized trials. We are facing today maybe a new era where we can not only think about experimental medicine on human beings, but we can model and simulate what we are trying to understand. So probably there could be a paradigm change in the next future where modeling and simulation will come before the clinical studies. But again, there are limitations of experimental models, and the extrapolation from experimental data from animals to humans, but we don't, always with caution. I like very much this sentence of Arthur Schopenhauer. There are 3 steps in the revelation of any truth. In the first, it's usually ridiculed. In the second, resisted, especially by doctors, who are very, very conservative. But in the third, it is considered self-evident. Everybody knew that. Now let's go back a little bit to endoscopy. And we all, where we are in an endoscopy room, are craftsmen, sort of blacksmith. We certainly have faced, and we were very lucky in my generation, extremely important progress in technology in the last 30 years. Think about the capsule endoscopy. 2001, the first trials, then the esophageal capsule endoscopy, then the colon capsule endoscopy appeared, and then probably in the next future we will have capsules that will be able to take biopsies, cut polyps, make hemostasis, and whatsoever. Craftsmen and blacksmith. We know that if we put a stent which is considered too long to be maybe harmful to the duodenum, we can cut with a sort of guillotine. We can, this is really a blacksmith work. With APC, tailor a post-insertion too long self-expanding metal stents. We can modify the plastic stent in order to fit better the anatomy of the ducts and maybe occlude later. Look, this is straight, this is curved. but with some boiling water, you can give to your stent whichever look, stent. You need a very, very curved stent because this guy is with a straight one will not go well. Just take it in the kitchen of the endoscopy unit. And you have your new stent. Some fresh water. Okay, perfect. You want to use a partially covered stent in a hilar stricture, which is forbidden by the literature. Just take your lighter or your cigar, and you burn a part of the covering. Do not tell it to Boston Scientific or to Cook, please. And you have the perfect stent for this case. Other examples. If you go into the literature to find out how to improve the speed of ESD, you will find dozens of tricks. Now, let's go back to EBM, in special in biliopancreatic disease, in this case. For acute cholangitis, we don't have to have randomized controlled trials. It is so self-evident that acute cholangitis, the best treatment is an early biliary drainage with the less invasive technique that you can have, endoscopy. But if you look at acute biliary pancreatitis, in this systematic review, there were 8 meta-analyses and 12 guidelines, okay? There is a lack of consensus, totally lack of consensus. Urgent ERCP, not indicated in mild acute biliary pancreatitis, but it's indicated in severe acute biliary pancreatitis with cholangitis and or persistent cholestasis. In the middle, in predicted severe acute biliary pancreatitis, regardless of cholestasis, 5 out of 8 meta-analyses said yes, and 5 out of 12 guidelines, so it completely blurred. Another guideline, which was produced a few years ago in Tarquinia on the use of capsule endoscopy for the colon, it was one of the statement was that capsule endoscopy could be useful for incomplete colonoscopy without any trial available. Now we have a trial comparing capsule endoscopy and CT radiography, which shows that capsule endoscopy is better. But in 2012, we didn't have it. So evidence may come from different solidity. And going to the conclusion, I think that the necessary gap, I fully agree with this colleague that wrote that the evidence cannot tell us when it is best to ignore the evidence. Because in front of you, you don't have numbers, you have a subject, a human being, with a history, a date of birth, a clinical history, a family history, a religion, yes or no, but you have a human being. So you cannot apply your ABM always to this human being. So evidence cannot teach us when it is best to ignore the evidence, except when you have a good teacher. I think that in medicine, teachers are still the most important, lucky moment you have in your life when you meet the right one. And I had this luck. I met this guy, Professor Michel Kremer, who taught me not only endoscopy but also French wines, life, science, for sure. A teacher that forges clearness. This is the Bible, what he calls the Bible. And this was the first time I was allowed to write in the Bible in 1983. It was a privilege. And this is the Bible, the same Bible we still have in Rome. Same. Of course, everything is also in a computer. Here, you can get all the information of the patients we have been treating. Provides you modesty. This is the Bible from 71, so the first ERCPs done in Brussels. Papille non vue. We didn't see the papilla. And then teach you integrity. Look at this, same, 71 or 72. Death because of excess of Valium, of diazepam. Having this clarity and integrity is extremely important in our life, but also in our profession. And communicates to you his passion. This was the last meeting we had before his death in 2008 in La Hulpe with many of the pioneers in ERCP. So really to conclude, I think that first we have to train the excellence. And as Aristotle used to say, excellence is an art won by training and habituation. We do not act rightly because we have virtue of excellence, but we rather have those because we have acted rightly. We are what we repeatedly do. Excellence then is not an act, but an habit. Then second, in your daily life, try to be curious. Don't stick to the surface. Try to get deeper information on what you are going on your evidence. And third, always be humble. This is something that Michelangelo Buonarroti wrote when he was 88 years old. I'm still learning. Knowledge is limited, imagination encircles the world. Thank you.